So last year we did choose your own adventure, but this year I'm giving the audience the control, and you guys get to choose the adventure for these guys. So with that phone, either scan that QR code or go to this website. All right, it's pretty easy. Just go into that website, and you guys can vote too if you want. And to make sure this thing works, let me know when you got that in there. Just a second. It's pretty easy. Just plug it in. It's just pollev.com/UCSF Napa. And it should pull up the first question to make sure this thing is working. So what is your favorite varietal of Napa wine? Is it Cab, Merlot, Chardonnay, anything made of grapes? That's for all the PAs, anything made of grapes. Good. Okay, so this thing looks like it's working. Excellent. All right. Good deal. So now, this will show up better on your phones, but choose your favorite new patient from my clinic last week. So each of these came in the last 7 days. So this is to show how ridiculous some of the stuff that rolls into UCSF can be. And for those of you who can't see it, this is what those pictures look like. But hopefully this voting thing is working. Yeah. And then there should be, is it showing all of them? There's a fifth one on. Oh, yeah, it's not showing option 5 for some reason. See more. Nope. Oh, I don't know why it's not doing that. Anyway, the fifth option is you get to be my junior partner and you get to take care of all of them. Been looking for one for 5 years. So taking control, these are the cases you guys get to pick from for patients. One was, it wasn't a tumor, but I lost 28 pounds. A cautionary tale of a surgeon who accepted gifts from their rep. Once upon a time in Mexico. Screw this cup. Or did anyone bring the duct tape? So first is going to be the great Dr. Ward. So everybody vote on what they want to be the case for Dr. Ward. I'll give it a few seconds here. Wait till we get about 20.
You can't see the duct tape.
They must know what the good one is here. So this one that's been selected, the cautionary tale, this is the craziest one. This isn't like designed to be like educational. It's more of just kind of fun here. So we will go to a cautionary tale of a surgeon who accepted a gift from the rep. So your rep sends you a text, Eric, says, hey, do you mind seeing a long family friend of mine? She's having some trouble with her hip, and she had surgery with Larry Dorr a few years ago. So of course you say, no problem, we'll get her in. And then you realize, like, wait, was Dr. Vale too backed up, or what's the deal here? And so patient comes to your clinic, you squeeze her in at the end of the day, and you get to look at the x-rays before you go in the room, and this is what you see. So you don't need to say anything yet, but just kind of swear at the rep and just be like, oh, damn it. So the gift, this is a 63-year-old woman. She's had 11 surgeries. The first one was when she was 21 because her hip didn't develop right. She had her last major revision about in 2016. 2 revisions for dislocation since that time with constrained liners, and feels like she's short. Feels something rattling in her hip. She's otherwise super healthy, super normal, but has a Trendelenburg and a short thing on the right. So where do you even begin when you get a case like this in clinic? Like, what's just your thought process for a disaster or something that's just outside of your comfort zone? Maybe this isn't your comfort zone, but what do you kind of think about?
When is my junior partner starting?
Yeah. I'm already here. Yeah.
Oh, yeah, that's true. I mean, obviously, first and foremost, rule out infection, right? So, going to do a full infection workup on her. It's the kind of thing where, this is, even if the inflammatory markers are normal, I'm still going to aspirate and, really try to rule out infection. I think having prior films is certainly helpful in this scenario. I think in this case, I'd also want to get full-length films on get more imaging, get more radiographs, and then prior operative reports would certainly be helpful too. But it looks like probably a subsided angled stem, and you're going to need to, at the very least, revise the femur or do a do a total femur.
Yeah, I think the one learning point from this one being like in these situations, like Dr. Parvizi was talking about, more data points is maybe helpful for infection. So if your ESR and CRP are normal, this may be one to kind of go a little bit farther and get a couple more points and things. And it might not show up really great up here, but there is kind of this big, large fluid collection that you can see. So I took some fluid out in clinic, and this is what that looked like. So those are 50 cc syringes, I think. Tons and tons of just kind of this brownish fluid. So get the labs, get the old films. I actually got a CT of this before we started. We're not going to go into how to rebuild this too much, but just kind of the workup. So these are some old films. What was I trying to show here? Basically just that thing's been dislocated before. They kind of had a bunch of cement around the new liner in the past, in this kind of middle film. There was a bunch of old cement, and now today, all that cement is kind of down here that used to be around the liner. And then on the CT scan, this thing's kind of coming out the back of the femur and has definitely subsided in the intervening years. So nothing grows from that aspiration, still normal ESR CRP. We repeated the aspiration again, and still nothing grew. So going into this reconstruction, what are you going to ask for? Constrained liner, socket has a history of multiple dislocations.
You get metal labs too?
Sorry?
Did you get metal labs too?
I did not, no. And then a subsiding stem halfway out the back of the femur, and new worsening pain, and this kind of effusion.
Yeah. I mean, so this is one where I think you really need to have the kitchen sink available for your reconstruction. If looking at that fluid that you pulled out and sort of considering that there's a stem with a skirted ball on it, I probably would also worry that maybe some of the genesis of this could be from a metal problem. So I kind of want to know that going into it. Obviously, this patient's going to have 0 abductors. I think one of the important pieces of it is if the stuff in the pelvis is stable, right? If that cup and augment is well fixed to the bone, then I'm not sure that ripping all that out and trying to reposition something up there is necessarily worth the effort, because you're still going to have the same abductor deficiency problem.
Okay. Before we get a little too far, everyone vote. What are you going to do for this one? Don't give Dr. Ward the easy answer here.
Option E. Yeah. Build a time machine, put the patient, wrap the time machine.
So, okay, we're getting a lot of A's and B's. So A's and B's, Dr. Ward. What's your plan in this situation? If you're going to keep the femur, get rid of the femur.
I think that I would. My first thought would be to try to keep the femur, but I think you're going to have a lot more information once you pull that stem out and you're actually able to assess the bone quality and assess what you have left. However, I have a pretty low suspicion that you're really going to be able to revise that and get a stable construct unless the bone around that allograft has actually reincorporated and healed reasonably well. I just don't think you have a lot of really good bone and isthmus to work with. At the same time, if you have someone who has a non-arthritic native knee, then I'm probably maybe going to give it a good try before I bail. But it's one where I'm certainly going to have the total femur, available, and I'm not going to sort of give it too many second thoughts if I just do the total femur.
Yeah, I'm going to move forward because this is just kind of crazy. But that was actually an older picture. The newer picture had it quite more subsided, and that middle section was quite loose. So, we went in there planning to do a total femur, and the knee portion first, we kind of prepped it out, dissected out the distal femur, go to the hip portion to take the liner out of the socket, and then the whole socket came out, and this is just kind of like more of show and tell, but the whole socket came out, and now you're just like swearing and like, God, total femur and a now huge hole. So, to reconstruct that, we won't go into too much, but basically like big hole, augment, big cup, dual mobility, and a total femur. and that's the femur that came out with the stem coming out the back, subsiding and loose. We kind of used that. We used pre-op CT to kind of figure out how long the other side was to build out the new total femur. Told her that she's going to hate her knee for a little bit. But she's now 15 months out, luckily not infected. I'm glad Dr. Parvizi left because I put these patients on antibiotics for life when they have that much stuff in there. But
You leave the patella alone?
Yeah, left the patella. Denervated the patella, but left. And then the ref's phone was blocked. So that's the only crazy one. I didn't put any other too crazy ones. Let's see. I can't control. Okay, so why is this not? There we go.
Jeff, did you do that all through the lateral?
I do a knee incision and then a separate lateral incision. Yeah, so like a big posterior and then a knee incision.
And did you try to get another stem in there?
I did not because, like I said, that thing was loose and in the midsection. If you go back, there's a scan somewhere. But in this midsection here, this was all kind of just wide opened, and I felt like potting a Wagner-style cone in the top of that was not going to last because it was going to basically be a tube like this potted on the top. I was never going to be able to chase it, and I felt like I was going to be in the same situation, and I don't like really cementing into that previous segment that's already had a big tube in it. So, I mean, there's definitely other ways to do it, but... Oh, shit. Okay. All right, so now this time for Dr. Kamara. We'll pick for him. Don't pick number 2. All right, good. All right. Once upon a time in Mexico. Struggling. Okay, this is not going to work. Okay, so once upon a time in Mexico, this is a 79-year-old female. She fell when she was in Mexico while visiting family 6 months ago. Unfortunately, it took her 3 weeks to get to the hospital, or for the hospital to be able to have surgery for her, and then was stuck down there for about 5 months because it was unable to travel due to pain and not being able to kind of mobilize. She's got some diabetes, COPD. She's short but thin, is in a wheelchair and can stand with max assist and has pain with any range of motion, has a healed, like very small posterior incision. And these are your x-rays, Dr. Kamara. So what are you seeing here? What's kind of the issue?
So it looks like she has a previous, can't tell if that's a hybrid or if it's an all cemented system, but it looks like there's some cement in the femur as well. So you have a Charnley-style cemented cup that has been flipped. And on the femur side, I can't really see that. It does look like there's some cement proximally as well.
Yeah, it's a cemented stem. You can kind of see it on the lateral there with some fracture stuff going on around the top. So, obviously this is something that's kind of loose and dislocated. What are in revision hips? What are your considerations in terms of bone quality? Does that change kind of what you're going to do, or just kind of walk me through your fixation strategies on a revision hip for something like this?
I think on the femur side, you have to look at the cortices, especially down in the diaphysis, because that's going to be where you're getting your primary fixation if you're going to be doing a cementless stem. For this type of patient, irrespective of the age, I think you usually have a pretty good diaphysis down there where you can get some type of revisions type stem. If not, that would be an indication for a long cemented stem, but be careful with that if you're going to do that, and make sure your anesthesiologist is aware. Consider venting the bone because you don't want to give them bone cement syndrome, higher incidence in this type of patient population. So my preference would be to do a cementless fixation on the femur. And on the cup side as well, although she is old, I think a cementless fixation should work there as well.
Is anyone on the panel using anything other than kind of Wagner-style stems as their primary mode of fixation, and if so, when? For revision hip, femur.
I think the only scenario is a cement and cement. So if you have, not in this case, obviously, but if you have a really good cement mantle and you can tap out a stem, cementing something back in. But other than that, no.
Yeah.
Yeah, so I'll still use a short modular cylindrical stem if I can get away with that.
And what are those? So that's your default, and then you will go to the more tapered style.
Yeah, if I have to do an ETO, I'll always use a tapered stem. But the majority of revisions are that we're addressing the femur is going to be for infection, and assuming that there's a relatively intact tube, a short cylindrical modular construct has excellent results, and it's what I grew up with, and it's pretty easy to use, and I don't have to worry about it subsiding.
Gotcha. So this, like any other case, you're going to get more studies, ESR, CRP. I'm assuming the panel gets that for every revision case as a screening tool. Does anyone do more than that, D-dimers or some of the other stuff we heard about?
On this one, I would aspirate it, because it came in from Mexico, and it just looks like whoever cemented it in didn't know what they were doing. And maybe wherever they were taken care of, everybody else didn't know what they were doing, so I'd be more comfortable getting an aspiration.
Yeah, okay.
Yeah, again, certainly everyone getting the ESR and CRP, I think, honestly, most people will get aspirates, but it depends on index of suspicion and sort of host factors as well.
Now, this isn't her scenario, but is anybody doing pre-op optimization for the more elective revisions in the sense of nutritional labs or, smoking cessation, other things? Is it the same as primaries, or do we have different thresholds, maybe going down the panel?
Well, I think it depends on the level of urgency. If it's an elective thing that can wait and you got unlimited amount of time, then you do unlimited amount of those kind of things, and as it gets more and more urgent, you start to cut corners. So it's a judgment call. This one, she's in a wheelchair. You're not going to make her stop smoking for a month. You're just going to go fix it.
Anything different?
It's a bit of a balance. Sometimes with these preoperative optimizations, I think they're very important. I think it's important to go into the surgery with all the tools that your team needs to optimize the patient, the team being your geriatrician, your anesthesiologist. That being said, short of sending them for an echocardiogram and a stress test, I haven't seen, in my practice, much actionable things being done for these patients other than just sort of like this person over here, they're in a wheelchair, delaying their case. So as Dr. Ries said, it's a balance, but I would like to see something more actionable being done off of those optimization type things.
Meaning, like if an A1C was high, something's changed, or what do you mean by that?
Not necessarily an A1C. That I think is routine in anyone's practice. If their diabetes is not well controlled, then they're not going to get their surgery. But those things sort of aside, she's 79 years old. My geriatrician is going to say, okay, we got to get the cardiologist. Then cardiologist is going to say we have to get a stress test. And I'm sort of scratching my head a little bit of times where I understand the anesthesiologist wants an echocardiogram. They want to know about the aortic stenosis. They want to know about the injection fraction. But it almost feels to me like sometimes these are roadblocks to care that don't actually lead to anything actionable. Haven't seen anyone get a catheterization in their preoperative workup, but.
Yeah, again, I think it depends on the urgency, and I think you can make an analogy to the hip fracture population. There's a number of studies that show that echoes are basically useless in the hip fracture population unless there's been some, very specific changes in symptoms for people. And so again, we don't want to throw up roadblocks, and it would be good to, sort of set out a criteria based on urgency about, what you can do.
The biggest concern I would have that way is post-op PT, because she's been sitting around for a wheelchair and had recent surgery and, all that kind of thing. So I think you do have to be more aggressive than aspirin with a post-op DVT prophylaxis.
For revision hips, anyone using aspirin routinely, or yeah? Dr. Kamara?
Yeah, we've been participating in the PEPPER trial for 7 years now, so we have a lot of experience with it, but I completely agree with Dr. Ries that I will change that, assuming the patient hasn't been randomized in the study, based on what I think their postoperative activity level is and what their age is and what their history is. So somebody who we're going to protect their weight bearing, who's older, that person's going to get, for me, is going to get a 10A inhibitor, not just aspirin, but I can't tell you that that's absolutely necessary. It certainly makes me feel better.
Our department made a high risk and low risk profile, and then for any revisions, we count those as high risk. So this patient would fall into that category.
Which gets what?
Lovenox. low molecular heparin for 35 days.
All right, and then in the interest of time, we'll kind of just squeak forward through some of the stuffs. Any thoughts if you did pull this out and wanted to, had a previously cemented stem that wasn't well fixed? Would anyone cement back into that envelope? Just not a trick question.
I think, as Derek said, if it's a nice envelope, if it goes very far distal, if you're going to do more damage taking it out and chasing it, if you have to do an osteotomy, meanwhile, you could get you could get appropriate fixation without having to expose the patient to that morbidity. I have no problem re-cementing into previously cemented femur.
Perfect. So grossly loose on both sides, had the chronic head dislocation that had kind of eroded away the top of the acetabulum. So we reconstructed this with a augment and a Wagner style stem. Kind of skip a little bit of this, but troch management for this one, abductor was still attached kind of on the side of that area there. Just kind of sutured a little bit of stuff together, but let the lesser troch fly. She is, I'm going to skip this stuff. These are some videos of augments. If anyone wants them, I can send them to you. But she's now 2 years out, has since broken the other side and had an inner troch fix there. Walks with a walker, has a little bit of abductor weakness, but says no pain and overall doing okay. All right. Let's see. Dr. Huddleston. Everyone vote one more time. If that thing's still open on your phone, it should give you which one we want to do. I can't see. All right, tumor. We'll do the tumor one. So this is a 76-year-old male. He's a professional singer. He had a history of bilateral hips done on the left side in 2012 and the right in 2019. No issues until the 8-year post-op mark when the left, so in 2020, the left side started getting an onset of severe swelling. So we went to his PCP. They started some Lasix, got a little bit better. Went to cards. They said, this isn't your heart. And then was eventually kind of made it to an orthopedic clinic. Has a history of AFib, bilateral shoulder replacements, kind of BMI 32, painless hip range of motion, has some mild psoas weakness, but really the only kind of remarkable thing on exam is just a lot of edema up to the thigh on the left side. These are his films coming into your clinic. It's the left side that's bothering you. So anything we see there, things that make you concerned or...
So just so I understand, so this is unilateral, non-dependent edema that started 8 years post-op?
Correct.
And it's painless?
Painless.
Okay. All right. Yeah, so I can't see the x-rays all that well, but it looks like there's some proximal bone loss, especially on the medial side by the lesser trochanter. I assume the implants are stable based on the history and based on everything else that I see. So that osteolysis is concerning. The question is why. So, infection, as we talked about, is always going to be in the differential diagnosis for somebody who has a painful hip replacement. So I would get screening ESR and CRP. This is almost certainly going to need to be aspirated based on what you show me, and there's probably going to be an MRI and or an ultrasound. But in this case, it doesn't look like it's a metal-on-metal articulation. My guess is this going to be an adverse local tissue reaction, so I would get serum metal levels. Assuming this is metal on poly, which from what I can see, that's what it looks like, I'd be concerned about corrosion at the head-neck junction.
Is there anything on this? So you kind of jumped to the metal pretty quick. Anything on this that just differentiates for you metal versus maybe an infection change? Like how do those look different, if they do?
So it's a modular neck now that I'm looking at a little closer. Is that
no, it's not a modular neck. It's just the
the
little notch on the corner. But is there any tips that you have? I'm asking because I don't know.
Well, so important things is this: the hip was functioning well for 8 years. It's leg swelling, so there's some obstruction, and you're showing us the case. So it's related to the hardware, not some other it could be a soft tissue tumor
it could be infection
elsewhere in the leg, for sure. But the history is not necessarily concerning for infection. So I'd be concerned about, so something's obstructing the femoral vein, and the question is what, and it's right around the hip joint. So it could be infection in theory from a fluid collection, but that's pretty unusual. So I've seen things like this with sequelae of metal, it looks like it's a 36 millimeter head, so that's a pretty good lever arm, and you could have mechanically assisted crevice corrosion at the taper.
Does anyone in their normal routine workup of a painful hip now check metal labs? Is that part of, Dr. Ward? Is that part of your work?
It's basically part of my my painful total hip workup lab is ESR, CRP, cobalt, chromium.
On the first visit, or is that usually a second visit kind of thing?
I actually check it. So I now check it pretty much for everyone with a painful total hip, just because sometimes, even if you have an operative report and it says ceramic, the operative report might be wrong. I think the corrosion issues are some of the most insidious, but also some of the worst problems that we can see because they're so insidious and so long-standing. And so it's something that if people are starting to have symptoms, I really don't want to miss, especially because I feel like it's something you could intervene on earlier and change an outcome.
I think there are some things radiographically that I'd agree with Hutch raise a suspicion of metal more than poly or stress shielding, because the ways you could get that bone loss is particulate debris, either metal or poly, or stress shielding. And the poly wear kind of has a scalloped demarcation as opposed to a diffuse sort of, invisibleness to it like this does. And the stress shielding would be symmetric on the two sides. So it really kind of those three points to metal. And metal debris generally causes more problem with soft tissue than bone. Poly debris causes more problems with bone than soft tissue, which is why you don't see a lot of things on the x-ray with metal debris, but it's probably going to show up on the MRI.
Perfect. So their inflammatory markers were normal, and this initial workup was done by an outside physician. Ordered an MRI, and came back with this collection around the hip. Was then kind of mistriaged and told, that it might be a tumor, and so was sent to ortho-oncology, who also kind of maybe could have asked us a little sooner, and we could have sped this up, but did a big workup for a tumor, did a biopsy, repeat MRI with contrast, obviously no malignancy there. So the diagnosis is, I've already mentioned trunniinosis. So I think for people in the audience, it's important to remember that when you're getting a hard-on soft bearing, that metal heads were the predominant articulation for a very long time. This is the AJRR data, and the blue line is metal, red is ceramic, and that while now most are kind of non-cobalt chrome bearings, previously that was the predominant bearing surface. And so getting metal checks, especially if you don't know what the bearing is probably a good part of the routine workup. So cobalt and chromium test. Cobalt was elevated higher than the chromium, consistent with a trunnion issue. And in the 9 months that it took to get to that diagnosis, now this is the new X-ray. So, Dr. Huddleston, just kind of in terms of what you're counseling this patient about when you have a metal on metal problem, what's that discussion in the office, and then what are you going to plan to do for this one?
Yeah, so I'm going to recommend that they have a revision and go through the whole explanation of there's a mechanical blockage of the drainage. That's what's causing the swelling, and the mechanical blockage is due to fluid collection that's generated from your soft tissue response due primarily to cobalt. And so the solution is to try to put something in that's going to alleviate any corrosion at the trunnion. So I tell them we'll probably be able to leave your femoral component. The amount of corrosion at the taper would have to be very severe for me to take that out. It looks like it's a blade type of stem, so I don't think it would be too hard to get out from the top, but I would prepare them that if we have to revise the stem, we may need to do an extended trochanteric osteotomy, and that's going to prolong your recovery and make it a longer operation with prolonged weight-bearing precautions. But assuming we can leave the stem. The next issue is whether we'll have to revise the socket or not. It looks like it's well fixed. And so we're going to put a ceramic head on and change the liner as well, keep it polyethylene. You do have to be prepared to revise the socket as well. I probably wouldn't hit on this too hard, and I'm not going to necessarily go digging around. I may do some particular bone grafting with demineralized bone matrix through the screw holes and potentially around the outer portion of the cup if I can get to it easily. But most likely you're going to be able to get away with just a head and liner exchange. Here, I think it's important that you do a very thorough debridement of the pseudotumor, and that requires getting the membrane out, and getting the membrane out just takes some time. It's going to envelop the entire effective joint space. You're going to have to peel it off the sciatic nerve, and so you just need to be patient about that.
Anybody doing anything differently, or?
I think the only other issue is most likely when you get this whole thing out, there's going to be so much soft tissue missing that it's pretty poorly vascularized. And this is like all the slides I think Jay was showing of the metallosis with that gray crud. And who knows, half the abductors might be gone by now, and you cut through the fascia and you're looking at the hip joint. It could be one of those, and if it is, they have a very high infection risk because it's just so devascularized. And I don't think there's any solution to that. Maybe you guys have something figured out, but other than a lot of antibiotics for a long time.
The other thing you need to tell this person is that we're going to try to get all of the metal that we can out of your hip, but we definitely can't get it all, especially the stuff that's now embedded in the bone. And I've seen cases where we've had the socket go on to become loose after it was previously osseointegrated, and this happens several years later from ongoing inflammation from the metal in the hip. So
Now you're scaring me.
that's uncommon, but I've seen it.
Yeah, I think you have to lay a lot of crepe with these patients. These are really can turn into really bad problems really quickly. So, all the standard revision kind of counseling stuff that you do for them, but also just very high risk of infection, very high risk of dislocation, very high risk of further problems down the road, and then also telling them that their metal. A lot of these patients then will focus on their metal ion levels after surgery for a very long time, and so you have to really counsel them that their metal ion levels will likely come down, but they may never normalize, and that may be okay.
I guess I'm in the minority. I didn't think that cup would actually tolerate, anymore. It seems like it's on its way to becoming loose, if not already loose. I would definitely test it intraoperatively, and I agree. I would try to do the minimal amount of surgery to give the maximum amount of benefit. And if it's stable, I guess the only other thing I would add is to consider looking into it and maybe consider putting a constrained liner in, or maybe even adding some more screws if there's some extra screw holes, because of the dislocation risk. Was it stable?
The cup was stable, yeah. So this cup was well fixed. So next question is, say this implant, you're revising for metal, and you're trialing and you're not super happy with your stability, and this implant has the ability to do a dual mobility option. Would you put one in a metal revision?
Yeah, so I wouldn't hesitate to do that. I would make sure that I explain to the patient why I would do that ahead of time. Basically saying the same thing that Dr. Ries said, is that all your tissues can be dead, and we're going to have to cut out everything that is dead, or you're probably going to get an infection. So I would not hesitate to do that, and I would probably do that over a constrained liner. I showed you the data on, malseating rate is high, the corrosion is definitely happening, but it hasn't been a problem clinically, and we could be burned by this in 5 years. But as of now, I don't think another adverse local tissue reaction is really going to be a big problem. So.
Yes, yeah, and I know I would probably not. I would probably try to do a lateralized lip liner and a longer head and lengthen them before I put in dual mobility. If the dual mobility junction was metal, if the dual mobility junction was not metal, then I wouldn't hesitate to. I worry about the longer term metal problem. Again, I certainly could be wrong. It may never become a clinically relevant issue, but I do worry about it.
The other thing is you can get a pretty good idea what the quality of the abductor is going to be based on the MRI. So you have an idea going in.
Yeah, so his MRI, the abductor looked pretty good. And again, he was still at this point only having kind of minor pain, which also kind of led me to this implant's probably still well fixed. So we had the kitchen sink available if it was loose, but tested everything, did some bone grafting behind, and actually got a little bit lucky. These were Smith & Nephew implants, so I could use an oxinium liner instead of a cobalt chrome liner, and was able to convert it to a dual mobility. But I'm kind of on Derek's camp that I'm more hesitant to put any cobalt chrome back in if they've had a metal problem, unless it's really the only option that's available.
So I have a question. You know, it looks like he's got exactly the same hip on the other side, and it didn't happen to that one. I realize they were put in 7 years apart, but does that have a non-metal head?
It's a ceramic head, yeah.
Okay.
Yeah, we did check that. But that is a question maybe. If he was asymptomatic, do you know it's the right side? Like, how does that change things?
Yeah, I think a lot of this has to do with sort of patient psychology and what they want. If all of a sudden they know they've had a metal problem on one side and they have a metal head on the other side, they may really be eager to avoid that potential future problem. And so if they want to, then, and they're willing to accept the sort of risk of surgery, I don't really have a problem going in there and doing a headliner exchange just to change it to a ceramic head if they have already had a metal problem. I don't know if anyone else would do anything different.
I mean, I wouldn't necessarily do that unless we had evidence that the person had an adverse local tissue reaction. So, you know, I've done an insert exchange on a healthy person for a knee where the post broke lifting weights, and the patient had a stroke and is aphasic after a half an hour operation. So no operation is free. So I would monitor the patients with non-invasive imaging before I committed to them to an operation.
This is some data from AJRR again, showing dual mobility usage for hip revisions. And so if we're looking at this, the red line is dual mobilities. And remember, this is anything coded as a hip revision. Red line is dual mobilities. Blue line is 36 heads. And constrain is the purple. I think this is, you know, the reason I put this in here is partly to show that, you know, dual mobility usage did come up a little bit, but also to show that AJRR, as much as we love it, it does have limitations. So some of this is a coding problem that you see those yellow line, that's less than 28 heads going up. That's probably mixed dual mobility constructs. And so, you know, dual mobility usage here looks like 20%. It's probably closer to 40. If we really look at it. So he's 6 months out. He almost, this was like crazy, like within a few days, lost all of that water weight and is very happy. He says it's great, but no dislocation, no infection yet, so we've dodged that bullet, but I'll have to watch him now since Dr. Huddleston said it's going to loosen. All right, we got like 4 or 5 minutes. So I will just show, let's do this one. This one's just a cool x-ray, so let's look at this one. So 47-year-old motor vehicle crash at 15, had a total hip arthroplasty placed. 3 revisions since. The last one was 2020 outside the U.S. Comes in with a cane and worsening pain for 6 months since a fall. Short and a little bit on the Colorado fat. Trendelenburg gait with a cane and a limb length discrepancy, and this is the X-ray. This is Dr. Ries's case. I remember this was like my first year in practice, I think, and like as soon as I saw this, I texted Dr. Ries within a few minutes. Like, what is this?
So what it is it's a ceramic on ceramic screw-in cup. Or actually, I'm not sure if it's ceramic on ceramic, but it is a screw-in threaded cup. And it's an old AML stem that probably got put in that position.
Yeah, so this is actually, it's a screw-in cup, exactly, and there used to be a poly liner that was placed inside of the screw-in cup, and so it was obviously eroded through that poly liner. So essentially a lysis case. In a case like this, what am I looking at? But then, normal workup for this one, ESR, CRP are normal. In an acetabular case like this, What is your studies going in? I know, Dr. Ries, are you good with just x-rays? Are you getting cross tables? Are you getting CTs for every revision hip? What's your
Well, I
planning?
would get a CT if, I can't figure out what's going on, which I can't figure out what's going on here. So I would get a CT, and I'm worried about, a discontinuity kind of happening intraoperatively and stuff like that. So I'd get a CT for the acetabulum. The other thing is that despite the appearance and all that stuff, this is probably a fully porous coated stem. Can't see. It looks like they cemented it in distally.
Yeah, I still don't know what's going on down there.
And it might be stuck in that position. Probably is. These old stems had this huge 14, 16 taper. So the way the tapers are, when they say 14, it means it's 14 millimeters at the top of the taper and 16 at the bottom. And, they stopped making those because the head-neck ratio was so bad, they all dislocated. So now they're like 11, 13 or 12, 14, which means, 11 on the top and 13 on the bottom. So you have to go to the DePuy guy and see if they can find one of these heads at the old warehouse in, in Warsaw.
Yeah. Okay, this was the CT scan, and we actually were able to find some old films. This was her initial hemi or something that was done, looks like bipolar, and then converted to this, and then has moved on to the problem that we have now with a bunch of lysis behind the cup. I'm going to skip some of this. I think this is cool just in the sense that when you are preparing to try and get pinch for a cup, you got to have the right bone. And so if you're going to do a jumbo cup, the reason I put it in is just when you're reaming, kind of bias that ream anteriorly. You don't want to just ream right down the center and get rid of all the bone. And I'll just kind of skip forward for this. But stem's well fixed. And anybody pulling that stem if they didn't have to in a 47-year-old? No, right? This actually, we had all the AML different types of heads, and it turned out to not be an AML. So now you have no head options. What are you going to do? Are you going to pull the stem, use the same old stem, or use old head? I just put the old head back on. Yeah. It's a 32. I would do. I also figured I might be coming back later in the future and have to revise that stem, so I didn't want to start that process at 47. I'll save that for another day.
Do you know what kind of stem it was? I mean, or did you never figure it out?
There was no markings. We had the 14, 16s, we had the 12, 14s for different companies. We had a bunch of them, and nothing fit on it except for the old one. So
you cemented in a 32 poly and
so
inside that.
Yeah, the cup on this is a little funky. So this was done when I used a non-modular cup, and then cemented in a modular one so that I could switch it later. It's a modular poly. So, anyone do post-op restrictions for their revision hips? And if so, how long? Bracing? Dr. Ries, maybe? And we'll just do like 5 more minutes.
Yeah, I do restrict them, and it's individualized both in weight bearing and dislocation precautions, because I worry about all that stuff a lot more. But it's kind of individualized to the situation you've got. I've never been a big fan of going as far as bracing them or anything like that. But generally for fixation, like the cup here, I would keep them on a walker, very restricted weight bearing for 6 weeks, and then see them and advance them probably over the next 6 weeks beyond that. So really 12 weeks of somewhat cautious advance in weight bearing. So I consider the weight bearing for the the bone ingrowth stuff and the dislocation precautions or limited activity and mobility for the soft tissue healing.
Yeah, about the same. Although sometimes in really tenuous ones, I'll keep them restricted for a full 3 months, and especially sort of big cup cages where you're sort of maxing out the cup, or triflanges, I'll sort of say, touchdown or some kind of restriction for a full 3 months, just to just to really slow them down. I don't think they actually do the touchdown very well. I think it just slows them down and hopefully gives you a little bit of time for it to incorporate.
I think there's a certain amount of common sense. You have to sort of see what you're dealing with. If you look at the person and all they're going to do is shuffle around on a walker, no matter what you tell them, then you just let them shuffle around on a walker and don't make a big deal out of it. But some of them are a little more, viable protoplasm, then you have to have a bit of a discussion with them.
All right, so we'll wrap it up with this. She's 3+ years out now, back to working. Still has a Trendelenburg gait, but I don't think I was going to fix that. So I think we'll wrap it up there. Thank you to the panelists, and thank you to all the faculty for all the time they put into this. And also thank you. Make sure you thank Aaron on the way out, who kind of runs this course. Derek and I just get the credit for it, but Aaron really does everything. So thank her, and thank the vendors if you see them. And hopefully you guys can have a good rest of the weekend in Napa here. So thanks for coming.